I want to start by saying thank you for taking the time to review this video. This is a program that we're passionate about, and we think it can make a real difference for people living with Parkinson's, and we appreciate your time. Parkinson's is an individual condition, and no two people will experience it in quite the same way. In particular, the person's response to medication often differs, so we encourage people to try not to compare or anticipate someone's response based on that of another. The four main motor symptoms of Parkinson's are recognized by the acronym TRAP, T-R-A-P, which is sometimes how people with Parkinson's will describe the way that they feel within their own body. The T stands for tremor. This is a rhythmic back and forth movement of a body part. It tends to be more pronounced at rest and should dissipate with voluntary movement and with focused action. Even though this is the symptom that people most often first associate with Parkinson's, it's worth mentioning that not all tremors are Parkinson's related. Not everyone with Parkinson's will show a tremor, and for those that do, it's unlikely to be their most disabling or disruptive symptom. In fact, Parkinson's is fundamentally about a lack of movement. In its natural state, we're talking about a condition that affects people's ability to move, and to do so safely, rather than causing them to move too much. And that brings me to some of the other symptoms. The R stands for rigidity. This is a muscular stiffness or weakness, and it's caused by a constant stiffness or contraction of the muscles. Along with this symptom comes a resistance to passive movement, which is movement that's applied from the outside or by another person. The A stands for Akinesia Bradykinesia. Akinesia is an absence of spontaneous movement, like a reduced facial expression or a slowed reaction. Bradykinesia is just slowness of movement. The P stands for Postural Instability, and as Parkinson's progresses, people may lose their natural postural reflexes, may lose an arm swing while walking and develop a stooped posture, and all of this leads to greater risk of falls. In addition to the physical symptoms, there are a number of common non-motor symptoms as well that are often not perceived or not recognized by staff as part of Parkinson's, and they are therefore undertreated. These can have serious complications as well. The average age of onset is around 60 years of age, and while people are being diagnosed at younger ages, the rate of incidence does increase with age. With Canada's aging population base, this means that the number of people with Parkinson's living in long-term care is set to increase drastically. The physical symptoms of Parkinson's first appear due to a loss of dopamine in the brain. Dopamine is a chemical that helps control smooth, coordinated muscle movement, and without enough of it, the symptoms of Parkinson's appear and activities of daily living become more difficult. In the advanced stages, a person with Parkinson's is extremely sensitive to a change in their medication routine. Because the symptoms first appeared when only 20% of normal dopamine levels remained in the brain, some years after having developed this progressive condition, very little naturally occurring dopamine is left. They are highly reliant on their medications, and getting the most out of each dose is essential. People with Parkinson's are constantly trying to balance the right amount of dopamine in the brain in an attempt to alleviate symptoms and reduce side effects. We're just looking for that balance. We're trying to keep people at the line of optimal dopamine levels. If we wait too long to give medication, or we're not giving it at a time when the body anticipates it, then the person with Parkinson's will dip below that line. Intervention with medication provides additional dopamine and can move people back up towards or above the line. The longer that we go between doses, or the farther that someone falls below that line, the harder it is to regulate them and for them to achieve proper health outcomes. When someone is in this dip area, they are more susceptible to complications, and they will require a higher level of care. Keeping people at the optimum dopamine level means that they are receiving higher quality of care, and you're seeing improved health outcomes in the patient, and their activities of daily living are much more independent. What this chart also illustrates is that there's a continuum of not being able to move to being able to move too much. People with Parkinson's are always seeking this balance, and proper medication timing helps achieve that. We're using the writing of the date here as an example, and while it isn't clinical, it does show the differences in symptom control. You can see here that Judy is in good control. Her motor skills are functioning well, and she's able to write clearly. You can also imagine how effective Judy might be at dressing herself at this time, for example, and how she could handle other activities of daily living. Now, we're about to see Judy in an off state, and here she's lost her fine motor control. This is just 2 days later. It's the same time, but she's missed her meds. Again, Relating this to other activities of daily living, try to consider the limitations that Judy will face with these things. Imagine asking her to dress herself or to brush her teeth, and imagine the level of care that she's going to require. Many people misinterpret this change in abilities as a choice, as someone intentionally being difficult or demanding. But the reality is, for many, like Judy, there is a huge difference between their ability to control their symptoms in an on state versus that of an off. Additionally, some people find that the effects of their medication doesn't last as long as it used to, so there can be times just before the next dose is due when the effects of the drug wear off and their Parkinson's symptoms return. The difference is that this is a more gradual reduction in symptom control as compared to the on-off phenomenon, which is a pretty quick change. In either case, the patient will require more care with simple activities of daily living that could otherwise be completed with minimal supervision or done independently, and they could be more susceptible to severe complications. In a facility, giving medications at prescribed individual times can be cumbersome. It might not coincide with present rounds, and it may cause some difficulty, but we know it's something that can ease the burden for everyone. If medication isn't given on time, staff will probably have to provide a higher level of care. However, if medications are given at the proper prescribed times, you should find that the person with Parkinson's generally requires less help with activities of daily living. Completing daily tasks when the person with Parkinson's is more mobile and independent means that the caregiver's job is easier, it's more efficient, and the quality of life for both people improves. So we think that it's a goal that's mutually beneficial. Further, when care of people living with Parkinson's is more efficient, staff resources are freed up to be spent elsewhere. This makes quality of care and quality of life much better for everyone at the facility. For a number of reasons, including the person with Parkinson's own difficulties communicating and insecurities about their environment and appearance, they tell us that they often feel misunderstood in a care setting and that their pleas regarding medication timing often go unheeded. I'd like you to hear from my friend Lorne.
My name is Lorne Collis. I'm 61 years old. I've had Parkinson's for about 6 years. This was about 2 years ago. I ended up in the hospital with an ailment unrelated to my Parkinson's. And I went 3 days with no meds whatsoever. And then I started on my Parkinson's meds. I was in the hospital for about 8 days. And at first there's a little bit of resistance from the nursing staff because, again, my schedule of meds doesn't correspond with their schedule of meds. But when I came home, it took me probably 2 to 3 months, maybe even longer, for my body to get back into a comfort state.
So that was Lorne. He's young and he's healthy. He does have Parkinson's, but he doesn't let his symptoms affect him in any great way. Goes into hospital with an item unrelated to his Parkinson's, and he has some difficulty with his medication while there. When he gets out, he goes from being the young and vibrant small business owner to a guy who can hardly get himself out of bed for 4 weeks. We know that if this can have a big impact on someone who's young and healthy like Lorne, it can have a big impact on residents living in long-term care who are probably considerably more advanced.
My name is Elaine Connor. I was a caregiver for a very good friend who had Parkinson's for 17 years. So we got to know a fair bit about medication and its effects and its side effects. And we were always very careful to try and keep it on time, all the time. She went into hospital for surgery after a fall, and subsequently she went to the rehab area nearby. There, the doctor instantly changed her medication schedule by cutting the dosage and changing the times. Despite my loud protests, his attitude was, I can't have my staff doing a schedule like that. They've got other things to do. In 2 days, you could really tell the difference. Her energy was down, her mobility was down, and her well-being was just not good at all. They added a little back, but it wasn't well placed, and she went to the other end of the short dyskinesias. Over a few weeks, she was battling other conditions and other drugs while she was not getting the full strength and energy and stamina that she might have had from these Parkinson drugs. So it was a real struggle. Finally, she had a severe stroke from which she never recovered. Now, I can't say, I'm not saying that this fluctuation and change in Parkinson medication was the sole factor or the only factor in this situation at all. But it certainly didn't help. It caused her a great deal of discomfort, and it certainly increased the stress level of all the rest of us. Just keep in mind that a Parkinsonian lives with a professionally, individually tuned medication schedule for good reason. Please follow it.
As discussed, a resident who is better able to function will be more independent, and therefore care can be provided more efficiently. For example, it will require less staff to go outside of medication rounds and care for a resident who is well functioning than for someone with motor difficulties and increased complications. This therefore frees up staff resources to devote to other residents. I thank you for your time, and we ask you to consider our solution.